Okay, let's talk about the kidneys. This is acute kidney and chronic kidney disease or failure, part 3. So, acute kidney injury, also known as acute kidney failure, so you will see both of those, is a sudden decrease in renal function from either pre-renal, intrarenal, and post-renal. And as you can, if you've listened to the other videos, you have seen um, different disorders for all 3 of these. So pre-renal kidney injury occurs from something before the kidneys. So think of something before the kidneys, right here. A major cause is usually dehydration, blood loss, or hypotension. All decrease of perfusion to the kidneys, which can cause some damage to the kidneys. You'll see the BUN and creatinine rise. If the pre-renal problem is not fixed, it can then also progress to intrarenal. So by not being perfused, the kidney is not getting the oxygen and starts to deteriorate. So the intrarenal is damage within the kidneys. So right here, this picture, intrarenal is within the kidneys. So think about the glomerulonephritis or an aminoglycoside antibiotic that causes kidney toxicity. Intrarenal causes problems with the function and the filtration of the kidney itself. And then we can talk about postrenal. So postrenal is can be considered like obstruction. So the kidney stones and so on, that would be an obstruction. And it causes a backup of urine into the kidneys. All of these cause toxicity, possible hypertension, backflow stasis, which could introduce bacteria in the urine, cause an infection. They can all eventually, if left untreated, cause major damage within the kidney itself, causing all of the inflammation and stasis and structural damage and filtration damage that can be unreversible. So hopefully things get caught soon. So think about the patient that gets a lot of urinary tract infections. They're going to get some damage, prolonged damage inside their kidney. And so the sooner that they can be diagnosed, the better. So what we want to do is treat each of them differently, just depending on the cause and injury site. So we've talked about intra and post-renal injury with the diseases we've already covered, right? So with pre-renal, we want to fix the problem to reperfuse the kidneys. So we need to reperfuse. So we need to fix what's going on in order to get that perfusion back. So if it's caused by hypotension, then we need to get the blood pressure back up. If the problem is blood loss, then we need to transfuse. Once the perfusion is fixed, then we can help kickstart the kidneys by giving maybe a fluid challenge. So we did give that quite often with the different types of acute kidney injury. We typically give 500 milliliters of normal saline bolus, so normal saline, so we give it right away. When we give that, we can give diuretics at the same time because they're typically hypertensive, but we want to monitor that blood pressure, so that's going to be dependent on the physician's orders and safety. But that fluid and then the diuretics helping push that fluid through can sometimes get the kidneys to start again. We want to control the blood pressure, if not by diuretics, then antihypertensives. And if it becomes more severe, then we might need to give them epigen, although that's a synthetic erythropoietin to stimulate RBC production. But typically, we're going to see that in our chronic kidney failure patients. So looking at chronic kidney disease or chronic kidney failure, so CKF, CKD, same thing. It's typically caused by a chronic illness. So think about that. Chronic kidney disease, chronic illness, acute kidney disease, acute illness, okay? So the the two chronic illnesses that are most at fault here for chronic kidney failure is hypertension and diabetes. So hypertension causes damage to the capillaries over a long period of time. So think about that. Here's my nice little kidney, and my high blood pressure is just shooting into this kidney really fast. Well, these are so fragile in here that the extra pressure that the blood pressure forces in can really damage the internal workings of the kidney. Now, with diabetes, with diabetics, if it's uncontrolled or just slightly uncontrolled for a long period of time, then they start to introduce large protein molecules to the kidneys. And as you can see and think, imagine your brain that large protein molecules would not really do very well when it's going through these tiny capillaries and nephrons. So that in itself would cause intrarenal damage. So with chronic kidney disease, as you can see here, 90 to 95% of the nephrons are affected, so they're damaged somehow. Toxins build up in the body as the kidney function decreases. Also, when urea is in blood, it also decreases the platelet ability to stick together, which can cause an increased risk of bleeding. So urine in the blood causes an increased risk of bleeding. The patient will typically have hypertension because of the lack of filtration. So remember, with this damaged kidney, it's kind of nothing is going through, so everything is backing up in the body. When the kidneys then are not being perfused with blood after the damage after a period of time, again, that RAS system will kick in to try to help perfuse that kidney, but it makes it worse by increasing that blood pressure and then putting more pressure into this kidney that nothing can go into. It's kind of like someone pushing up against a closed door. Anemia can occur as well because if it's damaged, then it's not going to be able to make that erythropoietin very well, and nothing is stimulating it to make the RBCs. So with CKD, we need to be concerned with the increased blood pressure, so we give antihypertensives to help prevent the onset of that damage from the hypertension. We can also give ACE inhibitors, which are very effective as it can help prevent the RAS system, because remember that angiotensin converting enzyme that goes to angiotensin 2, well, this inhibits that. And so it helps prevent that RAS system from doing its job fully. Calcium channel blockers as well, that's also going to decrease the blood pressure, but it can also improve the glomerular filtration rate depending on the amount of damage. So as you know, there's different stages to CKD. You'll be going over the stages in med-surg. We're just looking at the disease process and meds to treat it. So depending on the stage of the CKD is going to also depend on the medications that we give. So like I said, the calcium channel blockers can improve glomerular filtration rate and the blood flow to the kidneys, which is great. So if you're at the early stages of chronic kidney disease, then calcium channels will work well. Remembering that calcium channel blockers, as we'll learn ahead, also decreases blood pressure. Phosphate binders such as Renagel, typically more in the later stages of CKD, when there's maybe zero urine output or very little urine output, then our electrolytes are off balance. And so one of the electrolytes that we can help along with potassium and that Kxalate, right? That would be a good use for Kxalate. Is also phosphate levels. So their phosphate levels are usually very elevated, and so we can use a phosphate binder, Sevelamer, Renagel, Foslo, and they work just like Kxalate. They bind to phosphate and then it's gotten rid of in the stool. Epigen as well. So Epigen, if their RBCs are starting to show a decrease in production, then we can give Epigen, and that stimulates the red blood cell production. And that's just if someone is anemic and if they're asymptomatic. So it's a very expensive medication. It's given sub-Q, this one, and it really is for the mostly for the dialysis patient.